Yes.
he had today about why cases per 100,000 and where are the issues involved with these numbers.
Yes.
So should we start there then?
Okay, go girl. Let's see here. You want your first one?
Yep. So this is, again, hospitalizations. This is amazing data. Check this out. We're under 1,000 patients with COVID positive diagnosis. The entire state of Ohio, less than 1,000. And we dropped by, I think, over 100 in one day.
Plummeting. It's plummeting.
I mean, look at that. Minus 79% in the last 60 days. Look at the number of people in the ICU that are COVID positive again. Again, does not necessarily mean ill with COVID. And to understand how low we've gone, we are, what was that number up again? The ICU bed usage is at 266.
Yes.
Our minimum ICU bed occupancy, we are approaching very quickly. That was 184, and that was at the end of September. Wow. So we are rapidly approaching the lowest number we have ever had.
Well, that's why they can't use that indicator anymore.
We can't talk about that, and they just want to gloss over it and ignore it.
Yeah. And their response to that was that it's a lagging indicator compared to testing, and our response to that is bullshit.
Yeah.
Go pull up that first graph again for me. I mean, I have one all broken down to just that last thing. There is nothing confusing about what is going on in those bottom graphs.
No.
There's nothing in the way of high variability. I didn't get a chance to, I wanted to take a picture of the cases and all that, because he was claiming that cases went up and then hospitalizations went up. Yeah. Show me where that happened.
Not true, yeah.
There wasn't a lag between these, and there is no lag between inpatient and ICU.
The lagging thing is the whole fear mongering thing. They did that in the beginning too, Yes. Oh yeah, we're going to have tons of deaths, but we're just not going to know it for 3 weeks. They were even saying at one point they were going to have a massive number of deaths, but we weren't going to know it for like 7 or 8 weeks. It was so irrational.
Yep. But that's what we're saying. We're seeing there that no, I'm patient census and ICU census were tracking identical. Our peak date for both of those was December 15th. For both, they were identical. Yes. And that makes sense if you understand that some people get mildly ill, some people get more significantly ill, and some people get very ill. They're all getting ill at the same time. It's not like really a heavy progression. This is a timing thing. Exactly. All right, now with all this flipping around and stuff, I can't even remember what the next
This is your next slide.
That was my next slide. So, okay, we are told now that our path to freedom is 50 cases per 100,000. This is now our map. This is our number. This is our gauge. This is what everything is now revolving around. So our statewide average, as reported yesterday, and they confirmed that they will be reporting this every 2 weeks, or sorry, every week on Thursday. Yeah. It's not going to be like if we get under 50 cases per 100,000 on a Tuesday that will be released on that Tuesday. No, we still have to wait.
Right.
And so what you can see, there's several different things on this map that are very interesting. First of all, it is so pale yellow. I mean, just pale yellow. And the other interesting thing is
take more vitamin C.
Yes. So the other interesting thing about this map is that we were told today, yet again, that it's the masking, it's the masking, it's masking, it's masking, and kind of stuff. Now look at this map. Can you see a difference, an appreciable difference across this map?
Nope, better renormalize it.
It's very even. And actually, there's Holmes County sitting there, one of the least masky counties in the entire state, because that's where we have such a heavy concentration of the Amish.
Yeah.
And they're not masking, and they're not social distancing, and they're not doing all those things. They're going on with life as normal. And yet they are the palest on this entire map. They're trying to tell us that masking and social distancing is what is controlling the cases.
And that's BS.
Andy Thomas called it the passport to have things reopened.
Yep, the passport to have things reopened. But look, there's nothing. There is no indication that I know in some counties they're following it and they're not following in others. And we cannot see that variation within this picture. Right. Not at all. It doesn't exist because that's not what's controlling our cases.
No.
I'm trying to remember what I had.
Yeah, he said, he said, we've shown, I can use his banter. Now, we've shown that we have a powerful impact on the virus.
Show me.
He says that, but
this is what incenses me about the way they speak, and they being Andy Thomas and Vanderhoff, the architects of this whole thing, is that they constantly state things as though they're fact, as though they're science, and they give nothing to back it up. And in fact, it is lies, outright lies, which we give.
Yeah, so let's just go. I believe I know what the next one is. This is why I have Carrie here. So one of the things that they talked about, Dr. Vanderhoff talked about today, is again that it's, we're going to 50 out of 100,000 population, right? 50 cases at 100,000 population. There were a lot of questions from the media, why 50? Why is 50 the magic number? All these things. And, he comes back, Dr. Vanderhoff comes back and says, well, it's the standard number used by the CDC, and we do this, and we've been doing this the whole time. And then he goes on to say that in Ohio, because they think they know better,
right.
We are using 2 weeks as our cases per 100,000. And there was actually a question that directly addressed this. Somebody actually asked, hey, where on the CDC site can we find cases per 2 weeks? And Dr. Vanderhoff had to answer, well, they don't do it by 2 weeks. They just do it by 7 days. And this is a screenshot of exactly that website from the CDC. You can go there. I can drop this link in the comment section afterwards. You can go and mouse over all these different states, and it's the average daily cases per 100,000 in the last 7 days. And you mouse over Ohio, and you can see cases per 100,000 per last 7 days is only 107.9. Now go back to that yellow map.
Working it. Boom.
Oh, wait, our count is 179.6.
Oh, my goodness. So wait a minute. We don't agree with the CDC, Catherine.
Because we're counting for 2 weeks and not 1. So where the CDC would be putting us at 50 cases per 100,000, we would still, if we're at that consistent rate, we would actually show up as having 100 cases per 100,000, just because we're counting over 2 full weeks. So say you have 1 case per day for 2 weeks, total cases 14 for 2 weeks. But if we're only counting over 1 week, then it's only 7 cases per 100,000.
And he was somewhat deceptive with that today too. He said it's averaged over 2 weeks. No, it's totaled over 2 weeks.
Which
that's
is
different. And I think that's very misleading.
And so the other, to put up the positivity graph, the testing graph.
Oh, this one here.
This one here. So we're looking at a dropping positivity. This is the total number of tests given, both confirmative and antigen test, okay? Yes. We are now down to 3.1% 7-day average positivity. We are really low. I actually don't even know what the final day is on that one. I believe it's below 3%. And Dr. Vanderhoff, he repeatedly confirmed what I said, which is that we are doing about 50,000 tests a day. So that leaves us with about 700,000 tests given over the course of 2 weeks. And if you actually do the calculations, that comes down to, in order to get to 50 cases per 100,000 population, it's about 418 cases would be over 50, 417 cases per day would be under 50. That means that if we have 5,880 cases over 14 days, we are still above 50 cases per 100,000. If we are testing at 700,000 cases per, or 700,000 tests for 2 weeks, you would need a false positivity, a combined false positivity of just 0.86%.
The test isn't that good, Catherine.
And it probably isn't that good. So this goes to that list that I gave you, the black and white one with the box in it, the red box.
Black and white one. This one here?
This one here. So this is actually a copy of some of these tests. This is from, I can't even remember who it's from. This is actually from last year, from May. What they would do, I think it's the American Association of Pathologists.
Oh, yeah, where they were showing the percentages, yes.
So what they did is, in order to test the accuracy of these PCR tests, they would send out 3 samples to each of the, I mean, these are thousands of labs across the US that were doing PCR tests. And they gave them 2 known positives and a known negative to see what the accuracy of each of these kinds of tests at these hospitals, at these laboratory locations were, to get a better idea of exactly what kind of false negativity and false positivity that we have going on here in reality, in real life, in the wild kind of thing. And again, this is back, I think this is from last May.
Yeah, I remember we're doing that.
But the labs themselves haven't changed all that much. I mean, these are in EUAs, they're in the emergency use authorization. You know, this is the procedure. And if you look there, I've boxed in the sample that was truly negative. And if you look at the second line there, the BD Max, you can see that that 77 labs were using this BD Max at the time. And they only correctly identified a negative 75% of the time.
Yeah.
That means the other 25% of the time,
they were positive.
They called it a positive. Now, I know for an absolute fact that there's at least 1 location in the state of Ohio that is using the BD Max.
Yeah.
I don't know. I would assume there are probably other ones too. So we're looking at, you know, and there are quite a few on here that are showing up as 100% managed to get it. So that's pretty good. But we're also looking at, you know, what is our mix of tests that we have in the state of Ohio? We don't know. We don't have access to that information. The state of Ohio would have that information, I would assume. Yeah. But knowing this information, what are we actually coming to in terms of our false positivity? How much is our false positivity here? How many tests need to be given in order to reach that number of cases? Now, another thing I'd like to say about those cases situations, they did ask about probables. So if you could put up my daily probable. Today's probable, 38%. 38% of our cases reported today were probable.
So if you wanted to take the number of cases down really quickly, all you'd have to do is kick the probables out the door.
If you can kick out the probables, then we're done. Now, I think it was Jackie Borchard. I mean, it said Jackie B when she asked the question. Yeah, but she asked about the probables, and Dr. Vanderhoff, he danced, and he danced around this one pretty hilariously. Oh, I forgot the first part of your question. Yeah. And then he went on to say about the antigen tests. Right. And it was a term of art that they used. The probables was a term of art, and they were not certain about the antigen tests and how accurate they were early on. But now we know that a positive antigen test, we can take it to the bank.
Yes.
That a positive test is true. Hey, Carrie, would you like to talk to us about that? How the CDC feels?
You cannot modify an EUA from the FDA, because the FDA is a regulatory agency.
Yes.
So I think that's important to just straight out the gate. So if those kids are getting tested at OSU or wherever, and they're using an antigen test,
they're violating the EUA.
Yes, they are indeed.
Most certainly.
That's an important. Somebody asked the question a minute ago. They were saying, "Aren't we going to run out of people to test?" What I think you don't understand is that we're testing the same people over and over and over. Right? Yeah. Every student at OSU is getting tested twice a week.
Nursing home workers, everybody in pre-op for an elective surgery, every single person admitted to the hospital. And it doesn't even matter, because if you have strep throat with a negative test, if you complain of a sore throat, you're still counted as a case.
So if you go to those last 2 images that I sent you that were in the reverse order, there's the one with the blue banner at the top. So this is the website, and again, I'll put the link up. This was put up, I think, in like December, even November, where the FDA came out with a warning about potential for false positive results with antigen tests for rapid detection of SARS-CoV-2, and so on. So if you go put up the one with the underlines, if you go down in there, it talks about the positive predictive value and breaks it down, where if you have a population with 10% prevalence, 20 out of 100 positive results would be false positives. Okay, that's not great, but it's not horrible. But then you come to the next one there, where if you have a place of 1% prevalence, then 30% with a positive test actually have it. So 70% are false positives. Now, if you get all the way down to 0.1% prevalence, so let's say it's gone. I mean, as we can see right now, we are approaching herd immunity. The positive predictive value would only be 4%. That 96 out of 100 positive results would be false positives. And this is exactly what Carrie is saying here. When you have the false positive, when you have low incidence of the disease, I didn't know about the 5%.
It is
cutoff, but that means it's not going to be useful, and that's interesting. Yeah, you definitely need to get that link up there saying that you're not allowed to use it.
Yeah.
Look at what constitutes a case in the state of Ohio.
Yeah.
I mean, you have everything. You have a positive PCR test with symptoms or without symptoms. It doesn't matter. It's an antigen test with or without symptoms. It is a group of symptoms or even a single symptom. And if you happen to be part of a specific, very wide-ranging set of high-risk groups, you are COVID.
Really, yes. If we took out all the probables,
yes,
and we took out all the false positivity and asymptomatic testing, we're already below 50 per 100,000.
So for the numbers here, to be very clear, for the last 2-week period that was reported for yesterday, of those 179 cases per 100,000, 32.7% of those were probable cases. Okay, so I mean this was just today, but what I'm talking about is the yellow map. 32.7% of those cases that went into that calculation are probable tests. Now, I went back, I think it was about a week or so ago, maybe more, and I looked at the testing page. And I think I actually...
Reporter said, well, what about some of the counties that are already underneath that level? Why can't they have all their health restrictions? And I wrote it down. It was so mind-boggling to me that he said it. He says, no. He says, we've learned this year that it's just not safe to treat each of the counties different in Ohio.
So I just had a thought.
That's a direct quote.
I had a thought when you said that. Another question that he answered, somebody asked a question, a very good one. So right there, a county isn't allowed to have the stuff removed because we're all in this together. But there was a question about, well, you know, all these other states, they're removing restrictions. Won't that have an effect on us as Ohio? And his response was, nah, they're not going to have any effect on us.
Over test. They're reporting tons of probables. So one county could make the whole state stay under restrictions, just because.
So one of the things I saw when I was counting up all the probables on late Wednesday night and going through all those numbers, I noticed that some of those counties, most counties, when they had a peak in probables and then they went off and basically they're not nothing. And then there are some counties like Franklin and Cuyahoga and Hamilton and Erie and I think Delaware where they went up in a peak and then they went down a little and now they're flat on their probables.
So everybody else is going down, but they're not.
But they're staying flat on probables.
Yes.
Oh, that's another point I should point out here. We need 5,880 cases over 2 full weeks to stay in all the stupid. If we get under that, then
stay in all the stupid. That was a good one.
Then if we get under that, then we're free. The 2 weeks that we just experienced, there were 6,863 probable cases.
The probables alone keep us out of it.
The probables alone
keep us out of it.
Obamacare set up a system where physicians were owned, and now independent care is, you can't do it. You can't cross enough T's and check enough boxes to get the government reimbursement that you need to stay afloat in practice. So even if you are more lucrative in your business as a business of medicine, your overhead goes up so much percentage each year that you cannot stay independent. So doctors and physicians and healthcare workers are now owned, and that has effectively muzzled us.
Because if you, oh yes, this one.
This is from the Cleveland Clinic. They just changed this effective March 2nd. They're expanding COVID-19 testing access in Ohio to include asymptomatic individuals who've had close contact to someone with COVID-19. So right before Governor DeWine comes out and says, you will be free if we have lower than 50 cases per 100,000, we are expanding what we are testing. Now look what they are expanding to. A close contact includes anyone who has been within 6 feet of someone for COVID-19 with COVID-19 for 15 minutes or longer over a 24-hour period, has provided care for, had physical contact with, that's pretty broad, or shared utensils with someone with COVID-19. I mean, I read that as if you walked up to someone and shook their hands and walked away, you count, even if you're not within 6 feet for 15 minutes. According to this, that's what I read this as. Or we're exposed to respiratory droplets, coughing or sneezing. What season is this right now in Ohio? This is allergy season.
Yeah.
Someone's got an allergic cough? Oh.
Yeah.
And for these testing purposes, someone who has COVID-19 is defined as a person who has tested positive for COVID-19 within the last 10 days. The net they are casting is huge.
Yeah.
It's beyond huge. And that's why Dr. Vanderhoff, when asked the question of, oh, we're you know, our testing is going down, how will we know, and all that kind of stuff. And he was actually pretty honest there, saying, not going to be a problem.
Well, and then he was doing the whole new variant thing, you know, it's all, yeah, it's like, oh, well, no one can, no, he was saying nobody in the country can even predict what's going to happen with the new variant. And we know that the new variant is here in Ohio. And, you know, yet, you know what? We can predict what's going on. Why? Because we know the science. Thank you very much. Okay.
Well, they were giving credit to the vaccine for decreasing that curve.
Yeah, they were. Yeah, the vaccine is causing the weather to warm up too.
Show me that graph there. Show on that graph where we introduced the vaccine.
Yeah.
Where did it happen? I cut the dates.
One of these has a date on it. There we go.
Yeah, those have the date. Show me where vaccines entered the picture.
Right.
Show me.
After the peak.
After the peak. That's where they came in.
Yep. Yep.